We went back and did this ourselves in a pseudo-prospective way, because every study so far in 5-ASAs has done a case control study where they basically just looked at people retrospectively. What we did was we tried to simulate a cohort design where we went back to the mid-1990s and just took everybody who had a colonoscopy in the mid-1990s and followed them in a pseudo-prospective way for about 10 years into the early 2000s. And we saw who developed indefinite low-grade, high-grade cancer, and we were able from their charts to see whether they were on 5-ASAs, how much they were on, did they stop taking it. And so for each patient, we knew, of course we didn't do pill counts, okay, because it was retrospective, but we knew who was on 5-ASAs for how long. And we wanted to see if 5-ASAs work, where do they work? Do they work for people who have no dysplasia? Do they work once you've already had dysplasia? The punchline is that once you already have dysplasia, they don't work. Okay? You've got to catch people before they get low grade. We have some data I'll show you in a moment that for people who had indefinite dysplasia, although it wasn't statistically significant, the people that were on 5-ASAs did not progress. So maybe it works before you get dysplasia. We don't really know this because you'd have to study thousands of patients. We only had about 300 patients in the study. So this is the data from our study. So if you look overall at the progression to any kind of dysplasia or just high grade or cancer, we did not find a statistically significant lowering of the risk to progression, whether you looked at 5-ASA as any use, more than 2 grams a day, or average dose over time. So we cut the pie up as much as we can. There is a trend towards protection, granted, maybe a 30% protection from going to advanced neoplasia, but none of that was statistically significant. So at least from our pseudo-cohort design, we're not sure that 5-ASA is all that protective. But here are the patients who had low-grade dysplasia, and we looked at those who were on high dose of 5-ASA, meaning more than 2 grams a day, or low dose. And you can see that there was really not a big difference. If anything, the people on high dose 5-ASAs progressed more than people on low dose, but this was not statistically significant. But if you catch people before low grade, if you look at the indefinite group, this was kind of interesting to us. We had 28 patients who had indefinite dysplasia. The ones that were on high dose didn't progress at all in a long period of time. The ones on low dose 5-ASA were the ones that did progress. Now, again, it wasn't statistically significant, but it's kind of interesting. Maybe it depends on where the person is in their disease. And of course, some of the great work that's been coming out in the last year from Peter Higgins' group is the cost effectiveness. How do we put together our knowledge of 5-ASAs with our knowledge of surveillance? And in their well-done study, assuming that there's a colon cancer incidence of 30%, which may be true, maybe it's a little bit less than that, and we can think that 5-ASA alone may prevent about 49% of colon cancers. That's based on the literature. Without using any 5-ASAs, a colonoscopy every year prevented 89% of colon cancers and cost about $69,000 compared to colo every 2 years. But with 5-ASA, surveillance might be able to be lengthened. And I think Peter deserves credit, and his group deserves credit, for getting us to think about, can we integrate colonoscopy intervals based on what medicines the patient is on? And I think we need to see more data on 5-ASA and how it might interface with surveillance. Now, chromo. Anybody here doing chromoendoscopy for, I know you've done some great research studies looking in Lynch syndrome and sporadic adenomas, but is anybody using it for IBD patients yet? Peter is. I mean, I ask this question wherever I go. Very few people are doing chromo. You go to Europe, more people are using chromo. You have to learn what you're looking at. It is a bit of a learning curve. It's not that hard to learn, but unless you're wearing scrubs, you're going to go home and your shirt and your pants are going to be blue because it gets all over the room. Okay, so with chromo, you can see these kinds of lesions that, arguably a good white light endoscopy might have tipped you off that there might be something going on here. But when you squirt in indigo carmine or methylene blue, it usually highlights things a lot better. So these are the studies so far that have compared chromoendoscopy to white light and realized that some of these studies, because they're a few years old, and may not have been using the very latest high-definition white light technology. But be that as it may, every study has shown that you increase your pickup rate, your yield of finding dysplasia is 3, maybe even 4 times that of white light. This is the only study from the US. It's Jim Marion at our medical center. We found the same thing. You can find more dysplasias if you use chromo. The problem is we don't know what that means biologically. So you find more dysplasias. It's almost like, to me, it's like finding an ACF in a colon. What are you going to do? You can take out somebody's colon because you found an ACF, or 2, or 3. So we don't know what to do with the information. And in fact, when I asked the gurus in the world, Ralph Kieslich and Brian Saunders, there have now been a handful of patients worldwide, maybe about 10 or 12, that have gone to colectomy purely because chromo found more dysplastic lesions, and not one cancer has been found at the time of colectomy. So, you know, the people that do chromo say that's a success because we prevented cancer from happening. But if you're the patient, you might have kept your colon another few years. Colon is a handy thing to have around the house. So, you know, it depends on how you look at that data. But so we don't know whether we're changing the natural history of you know, based on chromo. Now, Peter, again, his group has done a nice job of helping us model this, understand this, because, you know, basically what this study did was it's asking what percentage of the colon has to be dysplastic for you to pick things up by random biopsy or by chromo. And what you can see here is that to detect dysplasia affecting at least 5% of the colon, I think 5% is probably a reasonable, you know, pickup rate. 32 random biopsies, which is around what we recommend these days, provides only about 80% confidence that you're going to find that 5%. You'd have to do 45 to 58 biopsies to get up to 90 or 95% confidence. Nobody takes that number of biopsies, I'm telling you right now. Even at Mount Sinai, where we study this, we're not taking that number of biopsies. In fact, studies have looked at, in the US, in Canada, in Europe, most physicians take less than 20 biopsies, so we only have about 60% confidence that we're finding dysplasia. So to achieve a dysplasia detection threshold equal to enhanced endoscopy, equal to chromoendoscopy with 90% confidence, would require taking 4,690 random biopsies. Okay. Everybody, go ahead. You go out there and do that. And the point is, enhanced endoscopy can detect much smaller dysplastic fields. It makes sense. You're squirting in dye, you're finding things, but what we don't know is the effect of that on cancer progression or cancer risk. So right now, these are the guidelines that we still live by. They didn't really change significantly when we put out this technical review last month. But basically, if somebody has no dysplasia, you have them come back in 1 or 2 years. If there's indefinite, you want to intensify the surveillance a little bit more frequently. If there's low grade or high grade in a raised lesion, and you've completely removed that lesion, you biopsy the base and you biopsy everywhere else, and there's no dysplasia, that person can remain in surveillance. You'd have them come back probably in 3 to 6 months. If you have high grade in a flat mucosa or low grade in a flat mucosa, most people would recommend a colectomy. But again, if you have low grade in flat mucosa, most patients, unless you tell them there's a 73% chance that they've got cancer there, they want to stay in surveillance, and you have to keep following them closely. So we usually begin at 8 years of disease. We don't care whether you've only had left-sided versus pancolitis. The old recommendations used to say that you wait for 10 or 15 years of duration if there's only left-sided disease. We tell everybody other than those with proctitis to start at 8 years. With PSC patients, the moment you diagnose PSC, you've got to do a colonoscopy. And that's when their meter starts. We repeat colonoscopies every 1 to 2 years. You might want to shorten the interval if there's active inflammation, if there's a family history, if there's PSC, if these anatomical abnormalities are present. You want to take representative biopsies from each segment of the colon. You can do chromoendoscopy if you have the expertise. It's not mandated in the new guidelines. And you want to pay attention to raised lesions and do for Crohn's what you would do for UC.